Mood disorders, also known as affective disorders, include major depressive disorder. Major depressive disorder is characterized by one or more major depressive episodes. The male-to-female ratio is 1 to 2, and lifetime prevalence ranges from 15% to 25%. Onset is usually in the mid-20s, and in older adults, prevalence increases with age. Chronic illness and stress increase risk. Approximately 2% to 9% of patients die by suicide. Symptoms of a depressive episode can be remembered with the mnemonic ck2. Sleep, hypersomnia or insomnia. Interest, loss of interest or pleasure in activities. Guilt, feelings of worthlessness or inappropriate guilt. Energy, decreased or fatigue. Concentration, decreased. Appetite, increased or decreased, or weight changes, psychomotor agitation or retardation, and suicidal ideation. Major depressive episodes can be present in major depressive disorder or in bipolar disorder types 1 and 2. Minors with suicidal ideation should be hospitalized involuntarily with or without parental consent, although parental consent is preferred. Disorders that can mimic major depressive disorder include mood disorder caused by a medical condition, substance-induced mood disorder, adjustment disorder with depressed mood, normal bereavement, and dysthymia. Mood disorder caused by a medical condition may result from hypothyroidism, Parkinson's disease, CNS neoplasm, other neoplasms such as pancreatic cancer, stroke, especially anterior cerebral artery stroke, dementias, or parathyroid disorders. Substance-induced mood disorder may be caused by illicit drugs, alcohol, antihypertensives, corticosteroids, or oral contraceptive pills, OCPs. Adjustment disorder with depressed mood presents as a constellation of symptoms that resemble a major depressive episode, but do not meet full criteria for one and occurs within 3 months of an identifiable stressor. Normal bereavement occurs after the loss of a loved one, involves no severe impairment or suicidality, and is characterized by waves of grief at reminders of the deceased. This typically lasts less than 6 months and should resolve within 1 year, though it may lead to major depressive disorder that requires treatment. Illusions or hallucinations of the deceased can be normal as long as the person recognizes them as such. Dysthymia is a milder, chronic depression characterized by depressed mood and 2 or more depressive symptoms present most of the time for at least 2 years and is often resistant to treatment. Subtypes of major depressive disorder include psychotic features and postpartum depression. Psychotic features are generally mood-congruent delusions or hallucinations, and psychosis occurs only during the major depressive episode, which distinguishes it from schizoaffective disorder. Postpartum depression occurs within 1 to 3 months after delivery, has an incidence of approximately 10%, and carries a high risk for recurrence. Psychotic symptoms are common in this subtype. Postpartum mood disorders can be classified into 3 subtypes based on time of onset and symptoms. Postpartum blues occur within 2 weeks of delivery and present with sadness, moodiness, and emotional lability. Patients do not have thoughts of harming themselves or the baby. Postpartum depression occurs 1 to 3 months post-delivery and includes the symptoms of postpartum blues plus sleep disturbances and anxiety. Patients may have thoughts of harming themselves and/or the baby. Postpartum psychosis occurs 2 to 3 weeks post-delivery and is characterized by delusions and disorganized behavior. Patients may have thoughts of harming the baby. Atypical depression, characterized by weight gain, hypersomnia, and rejection sensitivity, and seasonal depression, which occurs during a specific season, most commonly winter, and responds well to light therapy with or without antidepressants. Mnemonic for TCA toxicity, tri-C. Convulsions. Coma. Cardiac arrhythmias. Diagnosis requires depressed mood or anhedonia and 5 or more signs or symptoms from the ck2 mnemonic for at least 2 weeks. Treatment includes pharmacotherapy, with the best initial treatment being an SSRI, such as fluoxetine, sertraline, paroxetine, citalopram, or escitalopram. Partial responses to SSRIs can be augmented with bupropion or aripiprazole. Medications should be allowed 2 to 6 weeks to take effect, with doses adjusted as needed. Medication should be continued for at least 6 months beyond achieving full remission. If a patient fails to respond to the initial antidepressant, they may be switched to another first-line agent. Alternative or second-line agents include SSRIs include fluoxetine, sertraline, paroxetine, citalopram, escitalopram, and fluvoxamine. They are indicated for depression and anxiety. Common adverse effects include sexual dysfunction, gastrointestinal distress, agitation, insomnia, tremor, and diarrhea. Serotonin syndrome, characterized by fever, myoclonus, hyperreflexia, altered mental status, and cardiovascular collapse, can occur if SSRIs are combined with MAO inhibitors, illicit drugs, or certain herbal medications. Paroxetine should be avoided during pregnancy, as it may cause cardiac defects in the first trimester and pulmonary hypertension in the third trimester. Abrupt discontinuation of short-acting SSRIs can lead to discontinuation syndrome, presenting with flu-like symptoms, nausea, insomnia, and sensory disturbances. Atypical antidepressants include bupropion, mirtazapine, and trazodone. They are indicated for depression and anxiety, with bupropion also used for smoking cessation. Bupropion lowers the seizure threshold, but has minimal sexual side effects and is contraindicated in patients with seizure disorders or eating disorders. Mirtazapine may cause weight gain and sedation, but has minimal sexual side effects. Trazodone is highly sedating and carries a risk of priapism. SNRIs include venlafaxine and duloxetine, which are used to treat depression, anxiety, and neuropathic pain. Adverse effects include noradrenergic side effects at higher doses, and venlafaxine may cause elevated diastolic blood pressure. TCAs include nortriptyline, desipramine, amitriptyline, imipramine, and clomipramine. They are indicated for depression, anxiety, neuropathic pain, migraine headaches, enuresis, imipramine, and OCD, clomipramine. Adverse effects include sedation and weight gain due to antihistaminic effects, dry mouth, tachycardia, and urinary retention due to anticholinergic effects, and orthostatic hypotension due to antiadrenergic effects. TCA overdose can be lethal, causing convulsions, coma, cardiotoxicity with prolonged AV conduction and QRS, hyperpyrexia, and respiratory depression. Treatment for TCA overdose includes sodium bicarbonate if QRS is prolonged greater than 100 milliseconds, if the patient is hypotensive, or if ventricular arrhythmias occur, as it mitigates the depressant effect of TCAs on cardiac sodium channels. MAO inhibitors include phenelzyme, tranylcypromine, and selegiline, which is also available in patch form. They are indicated for depression, especially atypical depression. Adverse effects include hypertensive crisis if combined with foods high in tyramine, such as aged cheese or red wine, as well as sexual dysfunction, orthostatic hypotension, and weight gain. Most effective treatment is psychotherapy combined with antidepressants. Electroconvulsive therapy involves inducing a generalized seizure under anesthesia, typically 2 to 3 treatments per week for 6 to 12 treatments. Indications include refractory or treatment-resistant depression, MDD with psychotic features, need for rapid improvement such as active suicidality or refusal to eat or drink, catatonia, pregnancy, and bipolar depression or mania. Adverse effects include anterograde amnesia, postictal confusion, arrhythmias, and headache. Phototherapy is effective for depression with a seasonal pattern. It is important to rule out bipolar disorder before treating major depressive disorder because SSRIs can precipitate mania. Patients with 2 or more episodes should receive maintenance antidepressant therapy for 1 to 3 years, while those with 3 or more episodes should have indefinite therapy. SSRIs should be discontinued at least 2 weeks before starting a MAOI, and 5 weeks if the patient was on fluoxetine due to its long half-life. Clinical case. A 23-year-old woman complains of difficulty falling asleep and worsening anxiety that began 2 months earlier after she was involved in a minor biking accident, bike versus car, in which she did not suffer any injuries. Since the accident, she has refused to participate in any outdoor activities. What is her most likely diagnosis? Adjustment disorder, which consists of emotional and behavioral symptoms that develop in response to an identifiable stressor, lasts 1 month and 6 months, and does not have 5 or more symptoms of major depressive disorder. Persistent depressive disorder, also known as dysthymia, refers to a chronic depressed mood, including at least 2 depressive symptoms, or 1 in children, present on most days for more than 2 years with no symptom-free periods lasting longer than 2 months. Patients often report feeling depressed for as long as they can remember. Double depression is diagnosed if a patient meets criteria for major depressive disorder during dysthymic periods. Psychotherapy is the most effective treatment. Persistent depressive disorder is often resistant to treatment, and options to consider include antidepressants such as SSRIs and electroconvulsive therapy, ECT. Adjustment disorder is characterized by clinically significant distress following a profound life change, such as divorce, unemployment, financial issues, or a romantic breakup, and is not severe enough to meet criteria for another mental disorder. Patients develop anxiety or depressive symptoms, such as anhedonia, depressed mood, or weight loss, following a stressful life event, which is not life-threatening. Symptoms appear within 3 months after the onset of the stressor and typically resolve within 6 months after the event is over. Adjustment disorder causes social or occupational dysfunction, distinguishing it from a normal stress reaction. The best initial treatment is psychotherapy, focusing on coping skills and supportive counseling. No pharmacologic treatment is indicated. Premenstrual dysphoric disorder presents similarly to dysthymia, but symptoms are cyclic, whereas dysthymia is present continuously. Bipolar and related disorders are psychiatric illnesses characterized by episodes of mania or hypomania with or without major depressive episodes. A family history significantly increases risk. The average age of onset is 20 years, and the frequency of mood episodes tends to increase with age. Up to 10% to 15% of those affected complete suicide. Bipolar and related disorders are classified into bipolar I, bipolar II, or cyclothymic disorder. The mnemonic DIG fast outlines the clinical presentation of mania. Patients may report excessive engagement in pleasurable activities, such as excessive spending or sexual activity, reckless behaviors, and/or psychotic features. Mania is characterized by more severe symptoms, lasting at least 1 week or requiring hospitalization, causing significant impairment in social or occupational functioning, and may include psychotic features. Hypomania is less severe, lasting at least 4 days, does not require hospitalization, does not cause significant impairment in social or occupational functioning, and has no psychotic features. The symptoms of mania are summarized by the mnemonic DIG fast. Distractibility, insomnia or decreased need for sleep. Grandiosity or increased self-esteem, goal-directed activity, flight of ideas or racing thoughts, activities or psychomotor agitation, sexual indiscretions or other pleasurable activities, and talkativeness or pressured speech. Patients may or may not have a history of a major depressive episode, as outlined by the ck2 mnemonic. Antidepressants may trigger manic episodes if used without a mood stabilizer. Dopamine agonists, such as ropinirole, can also cause mania-like symptoms. Diagnosis is based on the duration of symptoms and clinical features as outlined in the DSM-5 for different psychiatric disorders. Sleep disorders include conditions such as narcolepsy, which typically presents for more than 3 months. Childhood disorders include tic disorder, disruptive mood dysregulation disorder lasting more than 1 year, attention deficit hyperactivity disorder, ADHD, persisting for more than 6 months, specific learning disorders, oppositional defiant disorder lasting more than 1 month, selective mutism, and separation anxiety. Anxiety disorders include phobias lasting more than 1 month, adjustment disorder lasting less than 6 months, generalized anxiety disorder lasting more than 6 months, panic disorder, acute stress disorder lasting less than 1 month, and post-traumatic stress disorder. Psychotic disorders include delusional disorder lasting more than 1 month, brief psychotic disorder lasting less than 1 month, schizophreniform disorder lasting 1 to 6 months, and schizophrenia lasting more than 6 months. Mood disorders include dysthymic disorder, cyclothymic disorder, major depressive disorder, and manic symptoms of bipolar disorder. Illustrates the diagnostic criteria by symptom duration, highlighting that psychiatric conditions have overlapping symptoms and presentations. Therefore, symptom duration is emphasized as part of the diagnostic criteria in the DSM-5. Symptoms must not be caused by substance abuse or a medical condition. Bipolar I is characterized by a manic episode, and a major depressive episode is not required for diagnosis. Bipolar II is characterized by a hypomanic episode and 1 or more major depressive episodes. Cyclothymic disorder consists of alternating periods of hypomanic symptoms that do not meet criteria for hypomania and depressive symptoms that do not meet criteria for a major depressive episode for at least 2 years. Treatment for bipolar I and bipolar II includes maintenance therapy with mood stabilizers, and most patients require lifelong mood stabilizer treatment. Lithium is the first-line mood stabilizer, used for acute mania in combination with antipsychotics, for prophylaxis in bipolar disorder, and for augmentation in depression treatment. Lithium also reduces suicide risk. It has a narrow therapeutic window of 0.8, 1.2 milliequivalent L. Adverse effects include thirst, polyuria, diabetes insipidus, tremor, weight gain, hypothyroidism, nausea, diarrhea, seizures, teratogenicity, 0.1% risk for Epstein anomaly if used in the first trimester, acne, vomiting, and hyperparathyroidism with hypercalcemia. Lithium toxicity, defined as a blood level greater than 1.5 milliequivalent L, presents with ataxia, dysarthria, delirium, and acute renal failure. It is contraindicated in patients with impaired renal function, sodium depletion, dehydration, and significant cardiovascular disease. Lamotrigine is a second-line mood stabilizer and anticonvulsant. Adverse effects include blurred vision, gastrointestinal distress, and Stevens-Johnson syndrome. The dose should be increased slowly to monitor for rashes. Carbamazepine is an alternative mood stabilizer and anticonvulsant used for trigeminal neuralgia. Adverse effects include nausea, skin rash, leukopenia, AV block, teratogenicity, 0.5%, 1% risk for neural tube defect, hyponatremia due to increased ADH release, and rarely aplastic anemia. Stevens-Johnson syndrome is a serious risk, and CBC should be monitored biweekly. Valproic acid is used for bipolar disorder and as an anticonvulsant. Adverse effects include gastrointestinal side effects, tremor, sedation, alopecia, weight gain, teratogenicity, 3%, 5% risk for neural tube defect, and rarely pancreatitis, thrombocytopenia, fatal hepatotoxicity, and agranulocytosis. Valproic acid is contraindicated in patients with hepatic disease. The best initial treatment for bipolar disorder is lithium. Acute mania is considered a psychiatric emergency because of impaired judgment and risk for harm to self or others. Mild to moderate mania can be treated with atypical antipsychotics, such as olanzapine or quetiapine. Severe mania is treated with a mood stabilizer, either lithium or valproate, in combination with an antipsychotic. Refractory mania may require electroconvulsive therapy, ECT. Mania or hypomania in pregnancy is treated with antipsychotics. Typical antipsychotics, such as haloperidol, are generally first-line and have fewer risks to the developing fetus than mood stabilizers. ECT can be used for severe or refractory mania in pregnancy. Bipolar depression is treated with mood stabilizers with or without antidepressants. The patient should begin taking the mood stabilizer first to avoid inducing mania. If monotherapy fails, a combination of a mood stabilizer and an antipsychotic may be used.